Yes, ma'am.
Okay, Bhagya. Okay. So the outline of today's topic would be introduction. What is the definition of difficult airway and the types of difficult airway? What are the challenges that we usually face in the tracheal intubation, especially in the ICU? How do you assess the airway in ICU patients? So what are the predicting factors in difficult intubation in ICU and special considerations during tracheal intubation in the ICU? What is intubation bundle, the different algorithms, and the intubation checklist? So airway management in the ICU is more challenging when you compare with that in the operating room. So why is it so difficult? Because the ICU patients have a compromised cardiorespiratory physiology. They have an increased risk of aspiration, and there is a presence of specific factors which are related to the environment, as well as if there is any presence of inadequately trained operators during that period of intubation in the ICU. So unlike in the OR, postponing of the airway management, it is not an option in critically ill patients because airway in such patients should be secured as early as possible. So the NAP4, the fourth National Audit Project report of the Royal College of Anesthesiologists as well as the Difficult Airway Society, they found that more than 60% of airway complications in the ICU, they will lead to death or brain damage. So coming to the definition of the difficult airway. So according to the American Society of Anesthesiologists, what is difficult airway? It is a clinical situation in which a conventionally trained anesthesiologist will experience difficulty either with mask ventilation, either with tracheal intubation, or both. So basically the spectrum of difficult airway starts from bag and mask ventilation. So it could be either difficult bag and mask ventilation, difficulty in inserting a supraglottic airway, difficulty in intubation, or it could be a difficult surgical airway. So these are all the spectrum of difficult airway. Now, this difficult airway can be divided into two categories. One is anatomically difficult airway, one is physiologically difficult airway. So anatomically difficult airway, these are nothing but the anatomical or the logistic barriers for a successful airway management. For this, you need to have a complete anatomical assessment of the airway. Okay, but what is this physiological difficult airway? This is most commonly seen in our critically ill patients. So basically, these critically ill patients have an compromised hemodynamics. They have impaired oxygenation or ventilation parameters, and there is a lot of metabolic derangement which happens in the critically ill patients. So such difficulties are known as physiologically difficult airway. Okay. So if you want to manage a physiologically difficult airway, you have to manage you have to optimize the overall patient condition in order to prevent this physiologically difficult airway. Otherwise, it may lead to peri-intubation arrest. Okay. So this will make the concept clear. So anatomical difficult airway could be, as I already told, the spectrum: difficult bag mask ventilation, difficult supraglottic device placement, difficult intubation, or difficult surgical airway. Now, physiological difficult airway is basically involvement of any of these systems. Okay, suppose in a neurological system, if the patient has raised ICP, then we will be confused to give what type of induction agents, right? If there is cardiovascular derangement, that if the patient has decreased ejection fraction or there is some arrhythmias, okay, or the preload, there is derangements in their preload or afterload. So any anesthetic drugs may lead to further hemodynamic instability in these patients. And if the patient has already the COPD patients or ARDS patients already experience hypoxemia and hypercarbia. So even a little delay in intubation or ventilation may lead to cardiac arrest. So like this, each system's derangements can affect our airway, right? So that is known as physiologically difficult airway. Similarly, some hepatic derangement like altered coagulopathy, right? It may cause increased chances of oral bleed or tracheal bleed, and renal derangements, especially hyperkalemia, where you will not be able to give scoline as a muscle relaxant, or if there is an abdominal compartment syndrome. And in severe sepsis, there could be a lot of contributing factors like lactic acidosis, or there could be a distributive shock or multi-organ dysfunction, where it becomes a physiologically difficult airway. And we can experience both together also, anatomical as well as physiologically difficult airway. Okay. Now, important is the challenges which we face during tracheal intubation in the ICU. So these challenges or factors can be divided into three types. One is ICU related factors, patient related factors, and operator related factors. So ICU related factors include infrastructure. Suppose if there is a lack of space around the patient, there is poor access to patient's head end, or there is poor lighting, or if there is no trained help available at that point of time, then that is a poor infrastructure. Or equipment. So there could not be availability of any fiber optic bronchoscopes or the supraglottic airways or in video laryngoscopies in some of the ICUs. Okay, so that is one of the drawback. Now coming to the timing. So emergency intubations can happen at any time, especially when it happens at night where the senior help may not be available. Okay, so that is one of the challenge. So these are all ICU related factors. Coming to the patient related factors. So in ICU, is it able to assess the airway properly as we do in the preoperative period? No, it is very, very difficult. And in some situations, it is impossible. Okay, because of the lack of time or because the patient being uncooperative. Second, there is a risk of aspiration because ICU patients are also or could be full stomach. We never know when is the emergency intubation, or there could be gastroparesis, which is associated with critical illness or sepsis. Okay, and challenging anatomy, especially this trauma patients. Okay, there could be maxillofacial trauma, C-spine injury, airway injuries, or burns patient. Okay, so all this causes a challenging anatomy for the managing the airway in these patients. Or there could be insufficient pre-oxygenation because ICU patients usually have shunts, VQ mismatches, or reduced FRCs. And they have a rapid desaturation capabilities because their physiological reserves are very less. And they could be having, because of sepsis, there could be some hemodynamic instability. So in order to use a particular drug, it would become difficult for us. And the last thing is waking up the patient is not an option in an ICU. Now coming to the operator related factors, like the training. Okay, that is very, very important. Okay, and what is the experience in ICU? What is the experience in endotracheal intubation? Because junior doctors who have newly just came into the ICU, the chances of them intubating is very difficult. So that might affect the patient's outcome. And important thing, the stress which is present in the ICU. So that is also one of the important thing which might lead to a difficult airway situation. Now coming to the commonest complications which might occur during tracheal intubation. So one is we can see a difficult intubation or you have a multiple attempts. Okay, that is the most common thing. Second, severe hypoxemia. Third could be hypotension because of the inducing agents. There could be increased chances of esophageal intubation, aspiration, and in some rare cases, even cardiac arrest. Now, airway assessment, especially in predicting the difficult airway. So usually we will not use all these mnemonics in the ICU, okay, because airway assessment in the ICU is a very difficult thing, but might be in your exams, especially the practical exams. If your examiner is from the anesthesiology background, might be he might ask one of these mnemonic. So just for your knowledge, so the mnemonic for difficult mask ventilation is MONS, means difficult mask seal or inadequate mask seal, obese patients, age more than 55 years, N stands for no or lack of teeth, and S for smoker. So greater than 2 of any these can markedly increase the risk of difficult bag mask ventilation. Second, difficult supraglottic airway disease, for which we have the mnemonic RODS. So R for restricted mouth opening, O for obstruction, D for distorted airway, and S for stiff lungs, or if there is any cervical spine injury. Okay, and next would be difficult laryngoscopy. So difficult laryngoscopy, the mnemonic is lemon. L for look externally. So what do you want to look externally? You want to see if there is any facial trauma, any large incisors, beard, mustache, or any large tongue. And you to evaluate the 3-3-2 rule. So what is this 3-3-2 rule? The first 3 stands for the incisor distance, okay, between the 2 incisor or the mouth opening basically, okay. It should be 3 finger breadth. Then the hyoid mental distance, this should also be 3 finger breadth. And the 2 finger breadth is nothing but the thyroid to mouth distance, okay. This is the 3-3-2 rule, okay. M stands for malampatti, O stands for any obstruction, especially in the oropharyngeal region, and N for neck mobility. And last one is difficult phono, that is front of neck axis. Okay, so here you have the mnemonic short. S for if there is any previous neck surgeries, like especially the thyroid surgeries. H for hematoma. O for obese patients. R for restriction, either flexion or extension restriction because of the previous radiotherapy, or if there is a tumor sitting in the front of the neck. So these are the mnemonics. So better to remember them. And there is recently one more easy way of assessing this difficult airway in especially either in the perioperative period or if possible in the ICU. That is nothing but the SARI index. What is SARI? It is simplified airway risk index, which takes into account the mouth opening, okay, the thyromental distance, the Malampatti score, the neck movement, ability to prognathe, what is the weight of the patient, and if there is a previous history of difficult intubation. So a lot of points are allotted for each of the component. So if the score is more than or equal to 4, then it indicates difficult direct laryngoscopy. Okay, so if you have time, you can just do this SARI index and you can assess the difficulty in laryngoscopy. So this is important for our ICU, okay? Predicting difficult intubation. This is for difficult laryngoscopy. This is for difficult intubation in ICU. So you have the Makocha score. So what does the Makocha stand for? So M for Malampatti score 3 or 4. A for any history of obstructive sleep apnea. C for cervical spine limitation. O for mouth opening less than 3 centimeter. C for coma, H for hypoxemia, and A for non-trained anesthesiologist. Okay, so each one has different scores. Okay, so basically they have divided this into factors related to patient, factors related to pathology, and factors related to operator. So the total score is 12. So 0 is an easy intubation, whereas 12 indicates very difficult intubation. So what is the advantage of this score is that it not only involves the patient-related anatomical difficult factors, but also it includes the physiological factors as well as the operator's experience. Okay, but what? So the sensitivity of this test is around 73%. And the disadvantages of this test is it has been not validated for the use with video laryngoscopy. Okay, so this is very important. Makocha score you need to remember. Now, if anyone asks, yes, how do you manage the difficult intubation in ICU? So you have to know this special considerations which we take during intubation in an ICU patient. So first important thing is there should be presence of 2 operators, among which one should be experienced in the airway management. Okay, so there are a lot of studies. Okay, so this is one of the study which was published in 2008 in the Journal of Anesthesiology. So they have shown that supervision by an attending anesthesiologist was associated with the decreased incidence of complications during emergent intubations. So you require 2 operators. One should be at least an anesthesiologist or any senior who is experienced in intubation. Second is you need to call for help at the earliest. Okay, so you have intubated 2 to 3 times, you have tried direct laryngoscopy, there is a lot of bleeding happening, and 4th or 5th attempt you are going to call your senior. then that is not the correct time, right? So when to call for help, okay, you should know that. So first, when the first difficulty in airway management is encountered, please inform to one of your sister or junior doctors to go and call your senior. Second, okay, you need more help. Okay, so when is it? When the final attempt at rescue mask ventilation fails and you're planning for an emergency cricothyroidotomy. At that time, you need more help. Okay, so these two are important situations where you need to call for help. The third one is the pre-oxygenation, which is very, very important in an ICU patient. And also the peri-intubation oxygenation, or also known as apneic ventilation or apneic oxygenation. Okay. So as we all know, oxygen desaturation is the most common complication occurring during intubation in ICU patient, which may sometimes lead to aborting the intubation attempts. So proper pre-oxygenation is important in order to prolong the time to desaturation and also to increase the chance of first attempt success at intubation. So how can we achieve a good pre-oxygenation in an ICU patient? Okay, yeah, we all do bag mask ventilation, but there are many trials which tell that NIV or using an HFNC will help securing a good or having a good pre-oxygen reserve before intubation. So 3 minutes of pre-oxygenation using non-invasive ventilation, which is delivered by an ICU ventilator, is more effective in reducing the desaturation than by face mask with bag and reservoir. Also, HFNC with a 100% FiO2 and a flow of 60 liters have also shown to be superior compared to the bag mask ventilation. So there are many studies which showed the benefit. So this is one of the study which showed NIV improves pre-oxygenation before intubation. So here the group is divided into NIV and bag mask ventilation, and they have shown that pre-oxygenation using NIV is more effective at reducing the arterial oxyhemoglobin desaturation compared to the usual method, that is the bag mask ventilation. Now, this is the second one, HFNC in pre-oxygenation. Okay, so basically here the patients were randomized into HFNC group and the other has high flow face mask group. Okay, and they have seen the primary outcomes and secondary outcomes. So what was the primary outcome here? The lowest possible SpO2 during endotracheal intubation procedure. Okay, and if you see for the high flow nasal cannula, the lowest possible was 91.5, whereas in high flow face mask, it is 89.5, which is not statistically significant. Coming to the secondary outcome, a lot of secondary outcomes, including even the morbidity in ICU, the length of stay, mortality at 28 days, everything, there was no statistical significance. So this was published in 2015 in the Intensive Care Medicine Journal. So despite what they have concluded, so despite the theoretical advantages, in acutely severely hypoxemic patients, HFNC as a pre-oxygenation device was not more efficient than the high FiO2 face mask. Okay. Now, in the same year, there was one more trial which has been done. The same use of HFNC to prevent desaturation during tracheal intubation in mild to moderate hypoxemia. The previous one was in the severely hypoxemic patients. Here it is mild to moderate hypoxemic patients. So here they have used the NRBM mask and the HFNC in pre-oxygenation, and they have shown that HFNC have actually significantly improved the pre-oxygenation and reduced the prevalence of severe hypoxemia compared to NRBM. So it could actually improve the patient safety during intubation. So this was a positive trial, but it is better to use only in case of mild to moderate hypoxemia. Now, there was a recent trial which was published, not recent, it was published in 2016, the OPTI-NIV trial. So what they have done here, they have used both NIV plus HFNC in pre-oxygenation. So they connected HFNC, upon that they have put an NIV. Okay, and they have compared it with only NIV. Okay, as a pre-oxygenation method. And if you see, there was no statistical significance either in primary or the secondary outcomes. Okay, so you can use either one of it, not to use both together. Okay, so they have recorded no significant difference between the groups in intubation related complications or in the ICU mortality. So the next is the hemodynamic stability. So intubation actually causes hypotension in most of the patients. And if you come to the ICU patients, nearly 50% of these patients may experience hypotension, and around 30% of the patients may experience a cardiovascular collapse also. So hemodynamic instability is one of the independent predictor of death following intubation, and it has also shown to increase ICU stay and hospital mortality. So how do you prevent this hypotension? So how do you optimize this patient? So while you are giving pre-oxygenation, also give some fluid boluses to the patient. So fluid resuscitation along with pre-oxygenation. Second, you have to be prepared if there is a intubation happening immediately after, hypotension happening immediately after intubation, you should be ready with your vasopressor support. Okay. And third, you need to select proper drugs for intubation, depending upon which patient you are intubating. Okay. So these three important things has to be seen to reduce the chances of hemodynamic instability in an ICU patient whom you want to intubate. Now, selection of the pharmacological agents. So benzodiazepines, propofol, thiopental, even if used in reduced doses, especially in ICU patients, they lead to decreased systemic vascular resistance. They produce myocardial depression and may cause precipitous fall in blood pressure, especially in the ASA 3 to 4 patients and those who have already having a hypotension, especially the septic patients. So the best agents in the ICU would be either etomidate or ketamine. But we all know that especially etomidate in septic patient may lead to adrenal insufficiency. No, but the effect is very, very low and there is no much harm. There are a lot of studies which have been done on this. So it just causes a transient adrenal insufficiency and it doesn't harm much. So you can use etomidate. And coming to the ketamine, because it has a lot of sympathomimetic effects, it helps in maintaining the blood pressure, but it may cause hypertension, tachycardia, increased airway secretions, raised ICP, and intraocular pressures. Unless contraindicated, even in, I think, raised ICP, you can use ketamine. So it is one of the preferred induction agent for endotracheal intubation in ICU. Okay. Other agents like opiates, dexmedetomidine, or lignocaine, they can be used as adjuncts to blunt the sympathetic response to laryngoscopy. Now coming to the next group of drugs, the neuromuscular blocking agents. So these neuromuscular blocking agents, they improve not only the laryngoscopic grade of view, but also the overall intubating rates. So they have been shown to improve the first attempt intubation success with both rapid as well as delayed sequence intubations, irrespective of the choice of induction agent or the route of administration. So the most commonly used one is the saxamethonium. Okay, but in contraindications, especially if there is a hyperkalemia, AKI, so where there is a contraindication, you can also use rocuronium at a dose of 1.2 mg per kg. And a lot of studies had showed a comparable speed of action and intubating conditions to saxamethonium. So better to use a scoline. If there is a contraindications to scoline, then you can use rocuronium as a muscle relaxant. Now coming to the device selection. So the DAS guidelines, most of the guidelines and studies tell that the ideal way of intubating an ICU patient is by using a video laryngoscopy. Okay, and it has shown that it increases the first attempt success and it improves even the glottic visualization during intubation. Okay, so there is a lot of studies and this is one of the meta-analysis which was produced in 2014 only. And they showed that video laryngoscopy could be useful in the airway management of ICU patients. Okay, because it reduces the risk of difficult orotracheal intubations. If you see the p-value, it is statistically significant. It reduces the grade of Cormac grade 3, 4 to around 2. And it also prevents esophageal intubations. So now next is, how do you induce these patients? Okay, the most common thing which we use is the rapid sequence induction. Why? Because most of the ICU patients, they are considered to have a full stomach, and securing the airway with the RSI, it seems logical here. So either we use scoline or rocuronium in this condition, and we usually apply the cricoid pressure, right? But in some situations, this cricoid pressure would actually obstruct our laryngoscopic view. So in such situations, you have to apply the cricoid pressure either partially or you completely release it to improve the laryngoscopic view and later to be reapplied. Okay. And gentle mask ventilation while applying this cricoid pressure before tracheal intubation can even prolong the time to desaturation and may be useful in those patients who have a poor respiratory reserve and in patients with sepsis. Now, drugs for RSI, yes, we all know hypnotics usually used is etomidate, ketamine, or propofol with the neuromuscular blocking agents like either succinylcholine or rocuronium. So pros and cons, if you have time, just go through it. Not so important at this situation. So, but you should know some differences between what is rapid sequence intubation and drug-assisted intubation. So rapid sequence intubation is nothing but the administration of pharmacological agents, including paralytic agents. So here, if you see, yes, hypnotics plus a neuromuscular blocker. Okay, so if you use a paralytic agent, then it is known as rapid sequence intubation. But if you don't use a paralytic agent and if you only use your pre-medication like midaspenta and one of the hypnotic, okay, so basically deep sedation, okay, that is known as drug-assisted intubation, and this is now becoming more popular in the ICU settings. Okay, so just if anyone asks, at least you should know the definition or the difference between these two. Now, confirmation of tracheal intubation. Okay, as I told, the NAP4 report, it showed that failure to use capnography, it contributed to 17 deaths or brain damage in ICU. And it is also associated with esophageal intubations and accidental tube displacements in around 82% patients, leading to death or brain damage. So, even the NAP4 as well as the DAS guidelines, they recommend the use of capnography for confirmation of tracheal intubation in all critically ill patients, irrespective of location, whether it is in the emergency or whether it is in the OR or whether it is in the ICU, all the critically ill patients, you have to use capnography for the confirmation of tracheal intubation. The last one is about the human factors and training. So airway management training should be an integral part of the training of any specialty which deals with critically ill patients. So use of simulation-based training will help enhance both technical as well as non-technical skills, and it improves the preparedness for highly stressful conditions. And you need to use an algorithmic approach and an intubation bundle, which may further improve your performance. Now, what is this intubation bundle? Basically, we'll first know what is bundle. Bundles are nothing but a structured way of improving processes of patient care and outcomes using a small, straightforward set of evidence-based practices, which when performed collectively and reliably have shown improved patient outcomes. So we have lots of ICU bundles. Okay, VAB bundle, intubation bundle. So lots of bundles. They might ask any one of the bundle. So you need to read all the bundles which are present in the ICU. Okay, so the first intubation bundle was proposed by Jaber et al. In 2009, and that was known as Montpellier Intubation Protocol. So this intubation protocol has been divided as pre-intubation, during intubation, and post-intubation. So pre-intubation, what does the intubation bundle, what does they recommend? One, there is presence of 2 operators. Okay, so before intubating or giving induction agents, you have to have a loading dose of fluid bolus around 500 ml, or that time they were using even starch, so starch around 250 ml. And preparation for long-term sedation. So prepare your midaspenta or dexmed infusions, and then pre-oxygenation for 3 minutes with NIV. This is the pre-intubation components of the intubation bundle. Now, during intubation, you have to do a rapid sequence induction and a cricoid maneuver or the Selix maneuver. Then post-intubation, you need to confirm it by capnography. And if the diastolic blood pressure post-intubation is less than 35, then you need to start the norepinephrine. This point is important. Okay, remember this point. And you have to initiate on long-term sedation and initiate the protective ventilation. This was the Montpellier intubation protocol in 2009 given by Jaber et al. But Coral et al. In 2018 have modified this Montpellier intubation protocol and got an update for it. Okay, so what does the update tell? So pre-intubation, same, 2 operators, fluid loading with early introduction of vasopressors. So they tell you load the fluid, keep ready the NORAD. Okay, don't wait for post-intubation diastolic BP to fall to 45. Okay, or start with a low dose vasopressor. Okay, then prepare for long-term sedation, same. Pre-oxygenation to be done, especially in the upright position. Your head end elevation should be 20 to 30. Okay, and pre-oxygenation with NIV. This is the 5 components of pre-intubation. In per intubation or during intubation, so they told that use video laryngoscope wherever possible. If suppose you don't have a video laryngoscope, at least Macintosh with stillet or bougie should be used. Okay. Next, RSI same, Selix maneuver same, and ventilation in case of oxygen desaturation of less than 90%, or if elevated risk of oxygen desaturation higher than risk of aspiration. Okay, in such cases, you have to give ventilation. Now, post-intubation, capnography to confirm, and you have already started vasopressor here. So, if the BP, diastolic arterial blood pressure is less than 35 or systolic BP is less than 90, then you need to increase the vasopressor dose. Start the long-term ventilation, and you have to keep low airway pressure ventilation, basically low tidal volume ventilation. And they used here recruitment manuals, but now nowadays I think recruitment manuals are not much of importance, and they told to measure the cuff pressure here. Okay, so this is the update of the Montpellier intubation protocol in 2008 given by Kroll et al. Okay, so please remember this. This is very important for you. And the next one is about difficult airway cart. So you should know what are the components in the difficult airway cart. Okay, and you should all be having this difficult airway cart in your ICU. So this basically this plan of arrangement is given by the DAS guidelines. So in the drawer 1, you are going to keep all the things which are necessary for the direct laryngoscopy. So you keep your Macintosh, or you keep your any type of other laryngoscopes, video laryngoscopes, face mask, ET tubes, Magel's forceps, stillets, bougies, everything will be kept in drawer 1. In drawer 2, you'll be keeping those things which are required for mask ventilation and alternate intubation plan. Like you have to keep your oropharyngeal airway, nasopharyngeal airway, devices for high flow nasal oxygenation, McCoy blade, flexible fiber optic bronchoscope. So this is kept in drawer 2. Drawer 3, equipments for rescue ventilation and tube exchange. Okay, the supraglottic airways, preferably the 2nd generation. Then you have to keep your AMBU. You have to keep your airway exchangers or catheters and a NG tube. And in drawer 4, you need to keep the equipments for emergency cricothyroidotomy. Okay, in case of complete ventilation failure. So what do you keep? You keep a wide bore cannula, you keep a scalpel, you keep a bougie, you keep a 6 mm ET tube. Okay. So next, coming about the stepwise approach or the different algorithms which you need to follow during the difficult airway or difficult intubation in case of ICU. Okay. So we'll first go with the older things, the DAS guidelines 2016. They have given this difficult airway intubation guidelines. Okay. So first step is about the pre-oxygenation and induction of anesthesia. So as we all know, pre-oxygenation, it requires 2 persons. Okay, either you can do it either with an NIV or a HFNC support. You can induce with either etomidate or ketamine. And as a muscle relaxant, you can use succinylcholine if contraindicated rocuronium. Use cricoid pressure and do give intermittent positive ventilation with either bag mask ventilation. Okay, so if your face mask ventilation becomes unsuccessful, then at a single attempt, you have to try to put the endotracheal tube. Okay, that is very important. So you're not able to, don't wait till you reach 100% or 95% of saturation. If you're feeling it is very difficult, just try to intubate this patient. Okay. So if your face mask ventilation is successful, then the next step would be laryngoscopy and tracheal intubation. What you need to remember is apneic ventilation is to be continued. So if you're using HFNC, you continue it throughout the procedure of intubation. Okay. And better to use a direct laryngoscopy, and maximum attempts what a single person can try is 2 attempts. Okay. And if you're not able to intubate it, at least you have to optimize the position, use a stillet or bougie if required, or if you want to change the device, technique, or operator, you do it. But throughout the procedure, you have to maintain the depth of anesthesia. Okay. So if you're successful in doing the tracheal intubation, then you need to confirm it by the capnography. Suppose you are not able to put the endotracheal tube, then the next step is to insert a supraglottic airway, at least to maintain the oxygenation. Okay. Here also, in order to insert it, 2 attempts are the maximum. Okay. And if you are able to put it, the supraglottic airway, then you can do 2 things. One is either you can go with a percutaneous or surgical tracheostomy, or if you're using a second generation supraoptic device, then you can actually intubate through the supraglottic airway device. Okay, suppose you're not able to even insert the supraglottic airway device, then at least before calling someone, and I think from here, from the laryngoscopy to all the next steps, you can call for help at any time. Okay, so suppose if you're waiting for the senior to come, you're not able to insert even the supraglottic airway device, then at least you do mask ventilation. That is very, very important. Okay, so if you're not able to do even the mask ventilation, then that situation is known as complete ventilation failure, where you need to call for additional help and you have to plan for emergency cricothyroidotomy. Okay. So if you're successful in emergency cricothyroidotomy, finally later you can convert it into tracheostomy. Okay. So this is the DAS 2016 guidelines. Now, in 2021, there is some change that has happened. So as I told, Makocha score. So the Makocha score in difficult airway has come, right? So there is some modification in this by using the Makocha score. So this algorithm is given by Jaber et al. And Driver et al. So here, yes, we require 2 operators, use a metal blade, if possible, a malleable stillet, and do a rapid sequence induction. So first is you have to assess the airway. Okay, so you calculate the Makocha score. So if you feel that the Makocha score is less than 3, then you can, it depends on the choice of the physician whether to use a direct laryngoscopy or a video laryngoscopy. But if the Makocha score is more than or equal to 3, don't go for direct laryngoscopy. Better do intubation with a video laryngoscopy. Okay. Suppose you are not able to do either with direct or a video laryngoscopy, that is known as intubation failure, then do mask ventilation. Okay. Then call for help and at least plan to do 1 more attempt. If you are using direct laryngoscopy, at least 1 more attempt of doing intubation with a video laryngoscopy, or use a intubating stillet. If that is not possible, then use a supraglottic airway, either the laryngeal mask or the fast track. Even that is not possible, then you can use fibroscope if you have availability in the ICU, or better to go for emergency cricothyroidotomy. Okay. So this is just a classification of the LMAs. So based on the generations, these are classified as first generation and second generation. So first generation is basically a simple airway device which has a low pressure pharyngeal seal. So because of the low pressure pharyngeal seal, it may or may not protect from aspiration, and it has no specific design to lessen the risk. So examples for this are the classical LMA, the flexible LMA, the laryngeal tube, or the Cobra. The second generation LMAs, they are actually designed specifically for the safety reasons. So they are made up of high pressure pharyngeal seal. So the risk of aspiration is decreased, and they may be more efficacious in ventilation also. Example for this is the Supreme LMA, the laryngeal tube suction 2, IGEL, and the sleeper. Now, based on the sealing mechanism, they are divided into cuffed perilaryngeal sealers, cuffed pharyngeal sealers, and the cuffless pre-shaped sealers. In the cuffless pre-shaped sealers, the most common example is our iGel. Okay. And the last classification is based on the number of lumens. So the single lumen devices where only it is used for ventilation, it is known as single lumen devices. Okay. Double lumen devices are those for ventilation as well as for uh, 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 what is it? Intubation. And triple lumen is additionally you have a gastric port in order to prevent aspiration. Okay. So these are the group of a lot of different supraglottic airway devices. Important one is which you have to keep in your ICUR. One is the intubating laryngeal mask LMA, iGel, and the last one is the ProSeal LMA. Now, these are some of the recommendations which we have already discussed. So positioning, better would be a ramped up positioning with a sniffing position. So ramped plus sniffing would be a better option. Pre-oxygenation, as I told, apneic ventilation is very, very important. So please give either NIV, pre-oxygenation or HFNC. Hemodynamics should be maintained pre-intubation, and laryngoscopy, better to use a video laryngoscope. Okay. And you should have an intubation checklist for all your patients. Okay. So if you're planning to do, at least if you're planning for an elective intubation, emergency, I do understand, but elective, at least you're planning. So you need to have a intubation checklist. So you need to prepare the patient. So see for the venous access, positioning of the patient is important. You have to assess the airway, proper pre-oxygenation. You have to optimize the hemodynamics, assure gastric emptying, and use of Scolin, and prepare the equipments. What are the equipment for that particular patient you require? So keep everything ready, even including the drugs. And you have to do team dynamics. So you have to assign each of your team member one work. So one will be handling suction, one will be drugs, one will be giving you the tube, laryngoscopes. Okay, so one will be doing the mask ventilation, one will be giving cricoid pressure. So you give, allot um, your team, one of them, one functions. And then you have to prepare for the difficult intubations. That is nothing but the plan A, plan B, plan C, and plan D, which we have already discussed in the DAS guidelines. Okay. Thank you. So next, Darshan would be taking the trauma.
Thank you, ma'am. That was a wonderful class. Is my screen visible? Okay. Good evening, everyone. So the further classes on a couple of topics on trauma and its associated management. So the first topic of trauma would be trauma-induced coagulopathy. Okay. So by definition, trauma-induced coagulopathy is a complex coagulative disorder which usually succeeds a severe trauma, and it is due to a dysregulated clot formation and breakdown. Okay, it can involve a spectrum of disease owing to coagulopathy that can be either a bleeding phenotype or a thrombotic phenotype, and sometimes even a mixed phenotype, similar to what we see in a case of a disseminated intravascular coagulation. Okay, similar to that, we have another condition called as TIC. Okay, so we all know this classical pathway of coagulation cascade, which involves the extrinsic pathway, the intrinsic pathway, and the common pathway. This is what we have been studying from our MBBS days, right? So there is a tissue injury activation of the tissue factor that starts on the cascade with factor 7 being involved, and subsequently even the intrinsic pathway gets activated. We all know this is actually a very good image which shows that roughly the bleeding time and the clotting time, all of that what is the timelines which is supposed to be present. So when the both extrinsic and intrinsic pathway get activated, what usually is the final focus point is the factor 10, which gets converted to factor 10A, which then acts on prothrombin, converting it to thrombin, which is again acted on by fibrinogen, forming a stable clot. Okay, this is what we see in the classical pathway of coagulation cascade. But right now, many other hematological society like the British and the American Society of Hematology, they have come with another way of explaining this, which is actually called as the initiation phase, amplification phase, and the propagation phase. Similar to any other case of a clot or bleeding, even in trauma, this follows the same principles. Okay, so going into the pathophysiology of trauma induced coagulopathy, the primary driver is the tissue injury, which releases the tissue factor from the extrinsic pathway. Because there is presence of shock and hypoperfusion, usually this would be compounded by the occurrence of hypothermia, acidosis, with the depletion of coagulation factors. Because in trauma, unlike any other event, the amount of tissue injury would be very high. Okay. The next important thing is the endothelial damage. If at all the patient has a penetrating type of injury, or an injury in multiple sources like both the thorax and the abdomen, this leads to a catastrophic activation of the coagulation cascade, which leads to consumptive coagulopathy as we see in DIC. Okay. So these are the primary drivers of trauma-induced coagulopathy. That is your tissue injury, shock and hypoperfusion, and endothelial injury. The mechanisms which happen is hyperfibrinolysis, because as we all know, once the prothrombin converts to thrombin in the presence of factor 10A, the fibrinogen has to get act there, and it should convert to fibrin. Fibrin is the one which forms the stabilized clot. Okay, so in the presence of tissue plasminogen activator, there will be breakage of this particular uh, a stabilized clot, which leads to hyperfibrinolysis. Okay, so this is what usually happens in the coagulation cascade. So this is the first trigger and the mechanism which happens in trauma-induced coagulopathy. Along with this, there will be dysfunctional platelet activation because of either reduced number or functionality of the platelet would be lost. How does the functionality matter? Because sometimes a proper clot formation does not happen because of a lot of other issues, probably the von Willebrand factor or the tissue factors, or the adhesion of the platelets would get hampered, because of which it causes dysfunction of platelets. Other things are quite simple and straightforward. Coagulation factor depletion, we all know, because there is a large rent or break in the tissue, the amount of factors which will be present at that particular time would be reduced. And this sometimes can also be worsened by our resuscitation, that is also known as dilutional coagulopathy. Okay, along with this, another important key mechanism is the inflammation and thrombosis crosstalk. Because of activation of the complement pathway and inflammatory pathway, there will be a mismatch between the pro and the anti-inflammatory parameters, which exacerbates coagulopathy. Okay, similar to what we saw yesterday when I was talking about burns. Okay, this usually would lead to a catastrophic triad called the lethal triad. That is the triad of death, which is hypothermia, acidosis, and coagulopathy. So, if you understood the pathophysiology, it starts off with the primary drivers like the tissue injury, shock and hypoperfusion, and endothelial injury. This usually causes hyperfibrinolysis, dysfunctional platelet activation, coagulation factor depletion, and imbalance in the inflammatory and the anti inflammatory parameters, which boils down to the triad of death, that is hypothermia, acidosis, and coagulopathy. Okay, so how does it look like? So imagine this patient who has come with major trauma. He can usually be seen as having a torrential bleed. So because of the bleed, there will be shock. Along with that, there will be tissue damage. Because of the shock, it usually puts the patient in a higher state or risk of development of acidosis. Because there is low circulating volume, we would have resuscitated this patient with some crystalloids or blood, and one of the cooler fluid. We wouldn't thought of having a pre-warmed fluid at that time, right? So that would lead to hypothermia. Along with this, if there is a major brain damage, the pathways which are present at that time would not think about conserving. Okay, similar to what we see in the ebb phase of the burns shock. Okay, so that is what usually happens. So because of this, you have already two things of the lethal triad present. Correct, that is shock. Shock causes hypothermia and acidosis. Resuscitative maneuvers further worsens the coagulopathy, adding to the third lethal triad of death. That is your coagulopathy. Okay, so all of this in together worsens the hypocoagulation. Okay, because of bleeding, there'll be a lot of consumption of clotting factors that also leads to hypocoagulation. Now, coming to tissue damage, because there is tissue damage and shock, what happens is the body goes into a defensive mode at that time. Because of the activation of the inherent homeostatic mechanism, the neurohumoral system gets activated, which causes increase in catecholamines, and it sets in a process of inflammation. Because of these issues, there will be platelet dysfunction that is due to endotheliopathy secondary to the activation of catecholamines, and because of inflammation, there will be hyperfibrinolysis. The best thing to understand hyperfibrinolysis is something like increased production of anti-clot forming agents like tissue plasminogen activator and activated protein C. Okay, so this in total worsens the coagulopathy, which is seen in trauma, and that is what is called as trauma-induced coagulopathy. I hope it is clear. Okay, so you have a patient with the bleed, shock will be present. Because of shock, you have the lethal triad of death on one side itself that can be precipitated or worsened by our resuscitative methods as well. That leads to hypocoagulation. Because of bleeding and tissue damage, there will be neurohumoral activation leading to platelet dysfunction, as well as endothelial dysfunction leading to hyperfibrinolysis. Together, hypocoagulation, platelet dysfunction, and hyperfibrinolysis leads to trauma-induced coagulopathy. Okay. So, coming to pathogenesis, I've told you in detail. So, if someone has a trouble remembering that, remember it like this. There is acute traumatic coagulopathy because of activated protein C, that is your endotheliopathy, neurohumoral activation, and that causes platelet dysfunction. Because of our resuscitative efforts, we have dilutional thrombocytopenia, metabolic acidosis, interstitial edema, and hypothermia. The detrimental factors in that particular patient, be it age, gender, or pre-medications if the patient is already on a anticoagulant or an antiplatelet, and genetic predisposition, and patients with TBI are usually prone to the occurrence of trauma-induced coagulopathy. I hope it's clear till here. So I've already briefed you. Quick looking at. So few of you might be thinking as to how coagulopathy would happen. Right here, I was mentioning to you guys about endotheliopathy and platelet dysfunction. How can that happen? How can it cause trauma-induced coagulopathy? How can it worsen bleeding? So this is a very beautiful image which helps you understand. So usually, whenever there is a bleed, there should be a vascular breach leading to the vascular response. That is, it causes the breakage or it exposes the subendothelial apparatus that causes the movement of the platelets towards the site of injury, later on activating the coagulation cascade as in progress, and that would form a stable clot. Okay, in this you see there is a lot of other factors, that is your Adam TS13, von Willebrand factor, okay, and other coagulation factors including fibrinogen. Okay, so what usually happens in trauma-induced coagulopathy is, because of hemorrhagic shock and hypoperfusion, there will be microvascular as well as macrovascular thrombus and inflammation. This usually, that is, the subendothelial apparatus goes into haywire. There will not be breaking down of the von Willebrand factor. That is, there'll be a presence of ultra large von Willebrand factors, decrease in ADAMTS13. The glycocalyx layer will get shedded. So the platelet would not know where to go and sit. Along with drop in the number of platelets, that is dilutional thrombocytopenia, there will also be dilutional coagulopathy, which ends up causing the trauma induced coagulopathy. So I think so this will help you understand in detail. Okay, this is the pathophysiology of trauma induced coagulopathy. So it is a complex interplay, okay, of coagulation, inflammation, and cellular dysfunction. Okay, the prominent role of inflammation and endothelial activation and dysfunction is what you need to take home. Okay, remember that the procoagulant anticoagulant mismatch would be present. So there is no standard definition as such for trauma-induced coagulopathy, but majorly it is divided into two types. That is your early trauma-induced coagulopathy, which occurs less than 6 hours, and late trauma-induced coagulopathy, which occurs between 6 to 24 hours. The early trauma-induced coagulopathy is usually of the bleeding variant, whereas the late trauma-induced coagulopathy is the clotting type. Okay, so this figure helps us understand this is a patient with a normal coagulation pathway. If you can see here, there is an image of a TEG. Okay, so the TEG shows there is proper clot formation and proper progression of the clot. Okay, so here all the factors are present in normalcy, but in patients with early DIC, they usually show a bleeding type. So probably there'll be a factor deficiency, platelet deficiency. So you can see the TEG graph actually has tapered down. If you can see late type, that is usually hyperfibrinolysis type of a picture. Sorry, I'm extremely sorry. In early TIC, you usually have the hyperfibrinolytic pathway, whereas the late TIC, usually you have the clotting type. Okay, here what happens is the clot would be formed, whereas the excessive clot which is formed would not be broken down, and that causes widespread thrombotic events. Okay, so the uh, hyperfibrinolysis type of picture usually happens in the early TIC. That usually causes bleeding, worsening bleeding. Okay, coming to how to diagnose a patient with trauma-induced coagulopathy. The clinical presentation, usually uncontrolled bleeding despite adequate hemostasis, should give us a heads up that this patient can develop trauma-induced coagulopathy. If there is a presence of shock and hypothermia with an end organ damage, probably the patient will develop trauma-induced coagulopathy. The routine investigations is your conventional laboratory investigations like PTA, PTT, INR, and fibrinogen. If you have point of care testing, that would be really good. Either a TEG or a ROTEM would help you understand the type of trauma-induced coagulopathy. Other indirect markers like your D dimers can help you understand whether the patient is in an active state of coagulopathy. Along with all of this, there will be other indicators of hyperperfusion like your base deficit, lactates, etc., which can help you understand the level or the severity of shock. Always remember these patients who are in a state of shock due to hemorrhage, they would be resuscitated with fluids, they would be resuscitated with blood products, because of which they would like usually end up in a state of hypocalcemia. Either it is one of the fluid shifts or majorly the blood product containing citrate can cause this. Okay, so this is some other adjunctive testing that would be usually necessary when you are evaluating a patient with a suspicion of trauma induced coagulopathy. So workup was done. So you have done along with all of the specific blood tests like your coagulation parameters and rotem. Routine blood tests like your complete hemogram, renal functions, liver functions should be necessary. There have been large studies which have done to check whether a TEG and a rotem is necessary always for managing a patient with coagulopathy, but there is no such evidence which is found. It was found that using your routine laboratory parameters would be sufficient enough. That is one of the reasons that there is no wide guideline telling that there is always a necessity to use your point of care devices for a patient with coagulopathy. Okay, that is your IACTIC study. So coming to the difference in features, early TIC and late TIC. So usually early TIC is defined by the increase in the PT and INR. I told you there will be the viscoelastic test will show poor clot strength and lysis. That is your hyperfibrinolysis will happen in early TIC. Coming to late TIC, it will be a shock predominant type of trauma-induced coagulopathy, and the patient, even though there is shock, will have a thrombotic picture. Usually whenever the patient ends up in this state, it's better to always discuss such cases with the hematologist, and based on the risk benefit analysis, probably the need for uh, heparin or any other anticoagulant should be considered. If there is an ongoing bleed, definitely no. If the shock is present but it is showing a thrombotic picture, then you should think of your other agents after definitely consulting with a hematologist. So, as in general, for any case of trauma, coagulopathy, and bleeding, the general measures should be followed. Prevent hypothermia in such patients. Prevent excessive use of crystalloids. Okay, restore perfusion and control bleeding at the earliest. Okay, that is the most important thing. I'll be discussing about specific measures when I will be talking to you about damage controlled resuscitation in the later slides or later class. Damage control resuscitation usually involves two important tenets, that is, your permissive hypotension and minimal use of crystalloids, targeting a particular blood pressure that is usually roughly around 90 millimeters of mercury in patients who do not have traumatic brain injury. Okay, as the ATLS guidelines go, the crystalloids that are specifically to be used in any case of trauma should not exceed 1 liter in the first hour. If at all, if you are unable to resuscitate the patient and your patient lands up in a grade 2 or grade 3 or grade 4, probably you have to transfuse them. Grade 2 is a red flag. Probably you have to keep a very close watch on such patients because they might slip into severe grades of hemorrhagic shock. Hemostatic resuscitation, you all know the proper trial, which came up with the use of 1 is to 1 is to 1 ratio of the plasma platelet and the red blood cells. Fibrinogen replacement, calcium replacement is similar, based on the level of fibrinogen which has been drawn from the patient sample at the time of arrival. Calcium correction, usually whenever you give 4 to 5 bags of blood product, be it RBCs, platelets, or FFPs, it's said that you need to replace calcium. The target would be an ionized calcium level of usually more than 1 millimole per liter. Okay, I will be discussing about specific targets in the session on massive transfusion protocol. Okay. Antifibrinolytics in trauma, there are a lot of trials which have come in. So there is definitely role for tranexamic acid, especially in early TIC. I told you, no, there will be a hyperfibrinolytic pathway. In that pathway, when you have the use of tranexamic acid, which blocks the activity of the tissue plasminogen activator, there has been good results, especially the crash 2 and trial has given you, and the matters trial also. Okay, so the best thing would be to initiate these patients as early as possible. Best results have been seen when given less than 3 hours of time. The first dose is 1 gram stat over 10 minutes, followed by 1 gram IV infusion over 8 hours. Okay. Always remember to correct acidosis and hypothermia. Need not give bicarb always. If you feel that the shock is present and the acidosis is worsening, only to buy time, probably you can do so. Otherwise, resuscitation with fluids and blood products should help you correct acidosis in such patients. Hypothermia usually happens because of blood loss, a failure of the body's homeostasis to maintain temperature, and the resuscitative fluids. So we have to keep a close watch on such things to minimize the occurrence of hypothermia. Point of care device, I told you IACTIC study didn't give us any larger data or guidelines based management, but if you have it, please use it for understanding. Don't use TEG or ROTEM if you have a lab which gives you your results earlier. Okay, if you have an obvious cause like thrombocytopenia, coagulopathy, then the use of TEG and ROTEM would not be much. Okay, so if you feel that the clot formation has some issues, probably at that particular time you can still think of working on your coagulation parameters, which the point of care devices like your rotem or teg will help you understand. Recombinant factor, it is usually used in severe refractory cases. Most of the data widely available are for post, cardiothoracic surgery patients or surgical patients. Trauma patients also, they have been tried when there is refractory shock which is present despite correction of all parameters. The dose varies on the type of bleed, okay, whether it is a post-operative bleed, it is an obstructive hemorrhage, or a type of trauma, okay. So routinely it is not recommended. Clinical endpoints, usually visual bleeds, if there are any like a open fracture, etc., you should see that it is taken care of either by surgical intervention or probably any interventional procedure. Look at the systemic signs, like this, your vitals should be stabilized, the hemodynamics should be optimized. Better to get a systolic blood pressure of more than 90 millimeters of mercury and a heart rate of less than 100 beats per minute. Organ perfusion, any of the three windows, your sensorium should be good, your urine output should be good, and peripheral perfusion to your organs like your capillary refill time, etc., should be improving. Okay, so these are the things that you can use as a rough estimate to understand the restoration of hemodynamic stability. Resolution of shock, as I've already told you, the improvement in mental status and peripheral perfusion is one of the earlier things that you see in resolution. Along with that, you will see your blood gases like your lactate levels and base deficit would start getting normalized. Biochemical, I've already discussed earlier, that is your lactate clearance and your base deficit. And acidosis also, in the meanwhile, would start getting better. Along with that, you have to optimize your other targets. Is usually patients with trauma-induced coagulopathy would be requiring some amount of ventilation. If just oxygen, if it's a smaller type of an injury. If it is a severe injury, probably they might even be on mechanical ventilation. So at that particular time, your oxygen targets should be roughly over 60 millimeters of mercury with a saturation of more than 94%. So hemoglobin, roughly more than 7 grams per deciliter for most of the trauma patient is the cutoff. In traumatic brain injury with cardiovascular comorbidities, roughly a higher target of between 8 to 10 is what is recommended as the transfusion endpoint or the transfusion trigger. If at all it drops below that, probably better to give them, because these patients are at a higher risk for developing cardiovascular events. Fibrinogen, roughly around 1.5 to 2 grams per liter is the target. Usually you can use your rotem, that is your fibtem should show a maximum clot firmness of more than 8 to 10 millimeters. Okay, this I've already discussed to you when I've spoken to you about the rotem parameters, if at all it is present. If you don't have rotem, don't break your head. A fibrinogen level of more than 1.5 should be sufficient enough. Thrombocytopenia, more than 50,000, don't do anything. More than 1 lakh is usually what is supposed to be the target for traumatic brain injury. Okay, so less than 50,000 in any patient of trauma, reserve your platelet count, keep a very close monitoring. Probably a 6 hour or a 4 hour platelet monitor would be good enough. If it goes beyond below that, you might have to transfuse. Okay. So PT-INR is supposed to be maintained less than 1.5, that is your INR, and PT roughly less than 13 seconds. Your ionized calcium, I've already told you, it should be more than 1 millimoles per liter. Thank you. Okay. Any questions? You can put it in the chat box. I also want to take some break. Okay. It's going to be more or less the same thing that I'll be repeating in the next two talks as well. It will overlap because they're all in the same thing. Okay. So it will be just like a revision for most of you. Okay. Coming to the next topic, that is your massive transfusion protocol. Firstly, whenever we talk about massive transfusion protocol, we need to know where do we do massive transfusion protocol, correct? So hemorrhagic shock is one of the most important places where we do it, be it a case of trauma, obstetric hemorrhage, or post-operative cases, correct? So these are the places which we anticipate the occurrence of major bleeding due to hemorrhage. Okay, So, hemorrhagic shock is defined as a life threatening condition resulting from significant blood loss leading to inadequate tissue perfusion and oxygenation. It is characterized by hypovolemia, reduced cardiac output, and cellular hypoxia, ultimately leading to an organ dysfunction, potentially leading to death if left unchecked or untreated. Okay. So the key features of hemorrhagic shock are the pathophysiology, which happens is there will be hypovolemia because there is decreased circulating volume. That leads to hypotension. Worsening hypotension reduces the volume, that is your preload, that can worsen the cardiac function, leading to decrease in cardiac output. Later on, because there is decreased cardiac output, peripheral perfusion to all the vital organs would come down, leading to tissue hypoxia. Correct? Worst case scenario, the cells would get affected at a molecular level. Later on, the by and large thing is whenever you draw a sample of blood, it will show the occurrence of metabolic acidosis. So, whenever you have a large bleed, the physiological response will always be present. Okay, how does it compensate? That will be by increasing the heart rate to maintain the cardiac output, vasoconstriction to maintain both the afterload as well as the preload, and activation of your renin angiotensin aldosterone pathway. Okay, so usually our body has a very beautiful system to check all of this. But if you have a large hemorrhage and these compensatory mechanisms are lost, then it will set in a cascading phenomenon leading to worsening of clinical state, ultimately leading to death. Okay, so how do we classify hemorrhagic shock? The American Trauma Society has a beautiful classification which is mandatory for all of you to know. This is something that you cannot go to your practical exams or even your theory exams without knowing. Okay. So, based on blood loss, what they define it as class 1, that is mild, that is usually less than 15% of the total blood volume lost, roughly between 750 ml to 800 ml in a patient of 70 kgs weight. Usually, the body can tolerate such blood losses and there will be minimal or no clinical signs. In class 2, it is called as moderate shock. In such cases of hemorrhagic shock, there will be roughly blood loss between 15 to 30%. That is, there will be a blood loss in volume parameters between 750 to 1.5 liters. Usually, at this stage, the patient develops clinical signs like tachycardia, decrease in pulse pressure, and anxiety. That is, your CNS also gets involved. Okay. In class 3, you'll see a severe type of shock, that is your hemorrhagic shock, because there will be blood loss between 30 to 40%. That is 1.5 to 2 liters of blood would be lost. Patient would develop shock. So class 3 is the place where you develop shock. Okay. Tachycardia would be worsening. There will be signs of hyperperfusion like oliguria and altered mental status present. Okay. In class 4, it's a severe life threatening type of shock. It's profound blood loss, usually of more than 40%, more than 2 liters in volume parameters. Because of this, there will be a large drop in blood pressure, that is profound hypotension, altered consciousness. In worst case scenarios, the patient can have a cardiovascular collapse and go into a state of cardiac arrest. So the clinical hallmarks I've already mentioned: hypotension, tachycardia, narrow pulse pressure, signs of hypoperfusion, and metabolic indicators like in your ABG you see a lactate of more than 2, like in case of septic shock as well, and a base deficit also would go up. So this is something that you need to remember along with your blood, loss parameters. So by and large, remember this is the American College of Surgeons, okay, and the American Trauma Society, which has also been endorsed by the ATLS classification of hemorrhagic shock, usually contains parameters like approximate blood volume. Okay, so you need to know it's 15, 15 to 30, okay, 31 to 40, and more than 40. This is something that they usually ask you in your practicals as well. Another important parameter they will ask is when does the pulse pressure drop, in which classification of, I mean, which class of hemorrhagic shock. And the next important thing they would ask is when do you trigger for massive transfusion, So usually massive transfusion is triggered when the hemorrhagic shock is in class 4. Okay. So 3, you should tell the blood bank to be ready. In when the shock worsens to class 4, initiate your massive transfusion protocol. Okay, this is something that you guys have to know. Another thing is resuscitative parameters like your base deficit. You can use this as one of the yardsticks. If you have a patient with class 2 hemorrhagic shock, if you have resuscitated them with a 1 liter of crystalloid, if you see that the heart rate becomes normal, like there will be a 20% drop in heart rate, there is an improvement in blood pressure with the pulse pressure becoming normal, and there is no change in sensorium, and there is good urine output, probably all of this along with your abg gives you an understanding that your resuscitation is good and this patient is a fluid responder. Okay, but if the patient doesn't do so, they can slip to class 3. If not checked, they can go to class 4. Okay, so this is a major understanding of hemorrhagic shock. Okay, so based on this understanding, there was another classification which was recently published in the Journal of Clinical Medicine. Okay, they classified it under 5 stages. Stage 1 is a mild or a stable type of a hemorrhagic shock. Okay, so patient's hemodynamics can be balanced by the compensatory mechanisms of the body, and no external supplementation would be necessary. Probably it's a very mild blood loss. If the patient goes into stage 2, usually some mild fluid challenges would be sufficient to stabilize the patient, and that's the reason they come under stabilized type of a hemorrhagic shock. Okay, so stage 3 is usually patient developing a hypotensive shock. They will require multiple fluid challenges, and despite those fluid challenges, they would be a transient responder. Okay, so these are patients who can worsen and go to stage 4 of or class 4 of hemorrhagic shock, or stage 4 in the current classification, with a blood loss of usually more than 40%. If not checked in any of this, and if there is a large bleeder which is present, the patient can exsanguinate and develop cardiac arrest. Okay, so this is by and large about hemorrhagic shock. This is the classic classification which was released in NEJM way back, I think so, in 2013 or 2011. Okay, so please mug up this slide. Okay, this is something that you have to know. This slide gives you both the classifications. I did this on purpose. You remember the blood loss parameters have to be remembered. The vitals parameters, that is your heart rate and blood pressure, should be remembered. If you forget pulse pressure, also they might let go, but you have to remember these two. Along with this, mental status changes. Usually the patient becomes anxious in stage 2 or restless. Okay, but confusion and drop in sensorium usually happens in stage 3 and stage 4. Okay, so whenever patient becomes anxious and confused and the patient is in shock, probably better to secure the airway. One of your things is secure, and then go about resuscitating these patients. Okay, so that will be in just about your hemorrhagic shock management. With this background, I will come to massive transfusion protocol. So this is something like a protocol which is different in different institutes. Okay, so this is a thing which does not have a universally accepted definition. Okay, that's majorly because it depends on your local infrastructure and whatever protocols that have been present. Okay, so that is one of the reasons it is not universally defined. Based on the infrastructure and availability, you have to modify the transfusion protocol. Having said that, it doesn't mean that we inadvertently do whatever we feel like, because there have been multiple trials which have shown that a protocolized management of hemorrhagic shock has better outcomes as compared to inadvertent or over usage of one type of a fluid, be it crystalloid, colloid, or blood. That has not shown any major mortality benefits. So, massive transfusion protocol is nothing but a standardized systematic approach to rapidly and efficiently replace blood and one of the blood products in patients with a life threatening hemorrhage. It is designed to optimize hemostasis, restoring the circulating blood volume to prevent any complications which are associated with either volume loss or massive transfusion. Okay, so there have been multiple, cutoffs which have been given, which are defined as
Can you show the previous slide again, please?
okay. Okay.
You, sir.
Okay. So it's nothing but a systematic standardized approach. That is what is massive transfusion protocol. That if you write that word, it's more than enough. It's majorly aimed at optimizing hemostasis. That is your prevention of continuity in bleeding. Correct. You have to arrest the bleeding and restoring the circulating volume. Okay, in a very systematic fashion. If you do it in such way, you will prevent complications either because of blood loss or because of excessive transfusion. Okay, so what are the usual criteria for massive defining massive transfusion? That is replacement of more than or equal to 10 units of black red blood cells within a span of 24 hours, transfusion of more than or equal to 4 units of PRBCs within 1 hour of ongoing hemorrhage, which is either anticipated or which is ongoing. Okay, replacement of more than 50% of total blood volume within 3 hours. Okay, so these are one of this is another important slide that you need to remember. Okay, this is something they will ask you if you are coming to Viva. You have to mutter it out like a parrot. You have to tell these three things. They'll expect you to tell this: replacement of more than or equal to 10 units of PRBCs within 24 hours, transfusion of more than 4 units of PRBCs in 1 hour, or replacement of more than 50% of total blood volume in 3 hours. Okay, this is one of the major reasons why there is no universal definition. Okay, is this correct? Is this foolproof? No. Okay, so I will tell you why it is not foolproof in the subsequent slides. Okay, or is there any better way for us to initiate massive transfusion protocol? So whenever we are thinking of MTP, we should have a goal. So I told you the earlier goal was stop bleeding when it is happening and restore blood volume as early as possible and prevent excessive transfusion of blood products and fluids. So this is what we have to do. It should be done in a balanced ratio. So what usually, which has been told, especially after a proper trial, is 1:1:1 of the PRBCs, fresh frozen plasma, and platelets. The complications like the lethal triad of death, which can happen because of volume loss or trauma-induced coagulopathy, should be prevented. Okay, that is your coagulopathy, acidosis, and hypothermia. What usually they say is the goal of MTP usually majorly leans on one parameter. That is your coagulopathy. They say that inadvertent resuscitation worsens coagulopathy. That usually is the only correctable arm which is most probably in our hands as compared to hypothermia and acidosis, because these two things are more or less the body's homeostasis has to take care. Even though you can give external warming, blankets, etc., and you can give bicarb to correct acidosis, that would be just like a band-aid on the wound above, but not addressing the core problem. Coagulopathy is something that we can understand and treat accurately. So this is what they wanted to do when they were thinking about massive transfusion protocol. Okay, what is diamond of death? One of you can unmute and tell.
Hypocalemia.
Sorry.
Calcium.
Very good, very good. Hypocalcemia. This is again caused by
Hypocalcemia.
us only. Okay, hypocalcemia. Okay, usually because we give a lot of, so transfusion again, what's one more thing which we were thinking, like it just causes dilution, consumption, coagulopathy, etc., but we also forgot hypocalcemia, which usually goes missed. Okay, unless you have a very good ICU setup, you have people like yourselves round the clock checking on the patients, this would usually be unchecked. So there will be a surgeon coming in, giving orders for transfusion, walking out. There'll be someone else coming in, giving orders for fluids, going out. If you're not checking these things, usually this diamond would set in. Inadvertent fluid therapy leads to hypothermia. Inadvertent transfusion leads to coagulopathy and hypocalcemia. Because of this, there will be worsening of hypotension, which is already there. That leads to acidosis. So, because of all of this, it will end up in a lethal diamond. Okay. So ultimately, if this is set in, it's really difficult to get this patient out and save him. Okay. The whole goal is to prevent the occurrence of this diamond of death. So why MTP? Firstly, it has a very clearly defined activation criteria. You saw, no? Class 4 of trauma, that is your hemorrhagic shock, you have to give the activation code and the products have to be released by your blood bank. You have the predefined blood products ratio, like your 1 is to 1 is to 1. So based on that, based on the weight of the patient, they will release. Protocols are there for monitoring and adjusting therapy based on either your clinical parameters and laboratory data. So that is why MTP becomes a very structured and a systematic approach to treat major hemorrhage. Okay. So, what are the tools for activation? So, earlier we saw that more than 10 PRBCs in 24 hours, more than 4 in 1 hour, so more than 50%. All of this is still ambiguous, right? We don't know. Sometimes the patient might have received, initial management elsewhere. They would be referred to you, and 24 hours is usually a large amount of time to wait, right? So, first 24 hours where your early trauma-induced coagulopathy would set in, you're wasting the golden period. Probably if you acted quickly, you would have already prevented your lethal triad and your diamond of death. Correct. So there are other tools which are available for activation of MTP. Can anyone unmute and tell what are they?
Dash score, ABC score.
Excellent. Rust and ABC. Okay. So along with that, there are a lot of scoring tools. Okay. No tool has been shown to be superior of other. Shock index has been widely studied. Your ABC score has also been widely studied. Okay. So these are few of the things that you can remember. There will be questions on what is critical administration threshold. Okay. Remember, this will be asked in your Viva. If they ask you what is CAT in trauma, the CAT in trauma is critical administration threshold, that is transfusion of more than or equal to 3 PRBCs in 1 hour period. Okay, so that is called as critical administration threshold. So this indirectly gives you an understanding that you need to activate MTP. Okay, remember here, it's 4 units in 1 hour. Your massive transfusion definitions. Okay, but here it is 3. Okay, that is the difference. I hope you can remember this. CAT, that is your critical administration threshold, it's more than or equal to 3 units of PRBC in 1 hour. Okay, coming to shock index, it's defined by heart rate over systolic blood pressure. If it is usually more than 1 after giving a 1 liter of bolus, usually it has a higher incidence of these patients worsening and the need for activation of MTP would be necessary. Your MTP and MHP means the same. Okay, MHP is major hemorrhage protocol. Okay, so similarly, one of you I have already told ABC score and RAP score. The ABC score has a thing like the components of ABC score are penetrating mechanism, systolic blood pressure less than 90 millimeters of mercury, heart rate of more than 120 beats per minute, and a fast on ultrasound being positive. If any two of the four mentioned parameters are present, then you can keep a close watch on such patients. These are the patients who will require the activation of MTP. Similarly, RAP score has the same thing along with the three parameters. What you need to remember is RABT does not consider heart rate or systolic blood pressure, wherein it uses it as a index. That is, it takes into consideration of shock index. Okay, so it is actually a better tool as compared to ABC or a shock index alone. Okay, that is the best point of RABT score. RABT is abbreviation of revised assessment of bleeding and transfusion. Okay, so usually it has a 78% sensitivity and a 91% specificity for the prediction. Okay, if you see here, as compared to ABC score, your RABT score is slightly better because it encompasses the use of your shock index. The type of mechanism is taken into picture. That is, penetrating wounds would be considered, and fractures are also taken into consideration. So these are probably better objective tools for the initiation of massive transfusion protocol. Is it clear? Okay. What are the seven T's of trauma, or rather trauma resuscitation? This is just for you to remember. No one will ask you. Okay. It is firstly whenever you have one of the earlier tools showing an indication for the occurrence of major bleed, start the plan. That is, your activate your MTP. It usually involves the team, usually the surgeon, the intensivist, and the blood bank officer. These are the major three people who constitute the team, along with other associated people, that is your nursing staff. Tranexamic acid, like I told you earlier, given before 3 hours, like a 1 gram stat over 10 minutes, followed by 1 gram over 8 hours, has shown to be beneficial. Keep a frequent testing, usually 1 hour period whenever you have activated your MTP. What do you test? You test for your coagulation parameters, you test for your electrolytes, as well as you check for your CBC, or like hemoglobin. Okay, along with that, blood gases can be done as well. Usually you transfuse to obtain a particular target, so keep those targets at check. I will be mentioning them in the later slides. Avoid hypothermia as and when possible. Okay, so keep the patient normothermic. Okay, that is what we need to try and focus on. There is no need for thinking of giving a warming blanket, etc. Just give a blanket, that should be sufficient enough. Warming devices for fluid and blood, if available, can be used. Once you reach the particular target, you need to terminate the code. So, by and large, the 7 tree of trauma resuscitation, just imagine that you have a patient, you activated the trigger plan, the team came into picture, you gave the tranexamic acid, you kept a check on the patient's vitals as well as the blood parameters, you checked if the transfusion targets are reached, you maintained the patient's temperature, and the patient is healthy now, and you terminated the code. Okay, so these are the 7 T's of trauma resuscitation. What are the steps for massive transfusion protocol? First step, identify the patients by using one of the tools I mentioned earlier. It can either be vital signs judgment, like your ABC score, your RAP score, etc., based on vitals, or objective scores. Okay. Also check whether the patient has a positive EFAS. Your scoring, usually your RABT score, takes into consideration all of this. Okay, so you can think about it. Whenever there is penetrating trauma, your shock index is more than one. There's a distraction injury, probably more than two. It's enough, right? So you can think about activation of MTP. So you've identified your patient. You've activated your institutional MTP protocol. Probably at this point in time, it would be very good if you can speak to the blood bank officer. Okay, if you have hands on and you have people to spare, please talk to them. That would be good so that you can coordinate it. So, what are you thinking of in the step 3? You have to prevent any coagulopathy from occurring. Better to give tranexamic acid as early as possible. I told you earlier, I'm repeating it multiple times so that it gets engraved. 1 gram within 10 minutes, 1 gram over 8 hours. Okay, avoid cold fluids that is necessary. Step 4, you need to have a proper ratio that is mentioned. Okay, so if you have a 1:1:1, it would always be better. 1:1:2 multiple trials, both your prompt, which was in 2013, and probably 2015 of your proper trial, both said that 1:1:1 should be sufficient enough. Okay. Whenever you feel that the patient's fibrinogen has dropped below 1 gram, or the coagulopathy is not corrected despite your uh, FFPs, your platelets, as well as your PRBC, you can use fibrinogen concentrate or cryoprecipitate. Always keep a check on your labs, your complete hemogram, your coagulation parameters, your fibrinogen, electrolytes. Majorly, because you're giving blood products, potassium and calcium should be checked. Along with that, check your renal function and arterial blood gases. Okay. Whenever you see that your targets have been achieved, you need to stop the MTP. Anytime you feel that the fibrinogen is less, you can use one of those concentrates or cryoprecipitate. Guidelines for calcium replacement in NTP. Each unit of PRBC or FFP contains citrate as an anticoagulation. So that is the one which actually chelates the calcium, right? So because of calcium chelation, the ionized calcium level in the body drops. So that is what you need to replenish, because calcium is also a part of the coagulation cascade, and the absence of ionized calcium would worsen coagulopathy. Okay. uh, I told you earlier, if every 4 to 6 units of blood products, better to give 1 gram of calcium. Anything you can use, either you can use calcium gluconate or calcium chloride. So whatever is available in your institute. One thing you remember is calcium gluconate is safe to be given both in periphery and central line. Calcium chloride should always be given in a central venous axis. So this is something that can be asked even in your viva. Okay. So please keep a watch about this. Okay. So if you remember this slide very clearly, most of their answers on calcium would be answered. If you're given a vial of calcium gluconate, you can tell them. Okay. You can lead them to this. Okay. So always given when the ionized calcium falls below 1 millimoles per liter, usually happens because of chelation of calcium by the citrate which is present in the blood bag. Okay. Calcium gluconate or calcium chloride are the available agents. Calcium chloride should usually be given by a CVC. Okay, whenever you see an ECG change like prolonged QT interval, worsening hypotension, coagulopathy, always think the possibility as hypocalcemia. That particular time, test and correct. Okay. So this is usually by and large what an MTP criteria activation protocol sheet should look like. Okay, this is one of the checklists which was actually published, I think so, in the British Society of Hematology, if I'm not wrong. I've taken it quite long ago. So they actually very clearly mention the first thing you see here is the activation criteria. Okay, so they have mentioned about the MTP protocol, that is your major hemorrhagic shock. They have thought about the initial measures, that is your damage control resuscitation. After that, they have also considered about cell salvage procedures, okay, to reduce the need for blood products. Then they have mentioned the individual doses, that is for platelets, your cryo, and your tranexamic acid. Along with that, they've also mentioned about other supportive care that needs to be given. Okay, very rarely, if the patient is on anticoagulant therapy either by warfarin or any other agents, reversal agents should be given, or your antagonist could be given. Okay, so based on that particular agent, you need to correct the coagulopathy. Okay. Remember, aspirin per se, if it has caused any bleed, you cannot do anything. The best thing would be to give platelets in such patients. Why is that?
Platelet dysfunction due to aspirin.
Uh, that's quite simple. Yes, good. But how? What is the mechanism of action of aspirin? It's an irreversible cyclooxygenase inhibitor, if I'm not wrong. I'm just recalling from my memory. Please correct me if I'm wrong. Okay, because it's irreversible, the only way If you have checked all the other parameters and you feel aspirin is the culprit at that particular time, that has to be corrected by a platelet transfusion. Okay, so that is why. Okay, so that is one thing. I have told you earlier also, there is no by and large guidelines telling the use for recombinant factor 7. Okay, it should only be given when all the other parameters are taken care of, all the other products have been used. Despite that, if coagulopathy is present, bleeding is present, that is causing shock at that particular time, based on the type and indication, that is your obstetric hemorrhage, or if it is your post-operative bleeding or a traumatic bleeding, you can consider the supplementation of factor 7a, that is your recombinant factor 7a. The dose varies between 90 micrograms to 20 to 90 micrograms, anywhere up to that. It depends on what is the inciting problem. Okay. Tranexamic acid, I've already told you multiple times, so I'm not going to dig in deeper. You need to know it's a tissue plasminogen activator inhibitor. Okay. Dose I've already mentioned earlier. Please remember, there are a lot of trials, a lot of articles on tranexamic acid. Read it. We have also mentioned, whenever we have spoken about upper GI bleed, we have spoken about trauma, etc. We are speaking about this, right? The role of tranexamic acid in trauma has been established, especially after your crash to end the matters trial. Okay, so remember the dose properly, and remember early initiation is the best way to maximize the utility of tranexamic acid. Okay, so this is the dose and timing. Okay, crash to trial, matters trial. So these are the two evidences for tranexamic acid. The 3 R's actually was derived from crash to trial. Okay. Coming to monitoring, you need to monitor the temperature, acid base status, ionized calcium, hemoglobin, platelet, PTA, PTT, and fibrinogen. How often do you do it? Depends on your availability and lab. Okay. So, what by and large most of the societies tell is 1 hour. Okay. If at all the vitals have stabilized, you can still wait, you know, doing most of the test. The best way is the most important thing is most of these things would usually get covered in your ABG itself. So ABG gives you a fair understanding of all of this. Only problem happens when you can't get these things, that is your platelet, PTINR, and fibrinogen. Correct? Temperature, very easy. You can usually use a bedside monitor, which is mandatory for patients like them. Correct? So this usually probably can help you understand by and large about it. If you feel that the lactates are going up, hemoglobin is still drawing down, or your hematocrit is going down, probably at that particular time you can do one of these tests. Okay, usually if you have a point of care device, use it. If you don't have, then probably consider using your routine investigations like your coagulation profile. There was a ratio which I mentioned earlier, like the golden ratio, 1:1:1, 1:1:2. What do we keep telling about? So, proper and prompt trial, these were the trials which actually were done to know what is the best ratio of blood products that are necessary in a patient with trauma. So, I told you in 2013, there was the prompt study group which performed a prospective cohort study demonstrating that a higher plasma, PRBC, and platelet ratios conferred survival benefits in the first 6 hours. But when the ratios were below 1 is to 2, 3 to 4 times higher likelihood of these patients dying was present when it was compared with 1 is to 1. So they came to an understanding that if you give a lot of blood products in the prompt trial, it indicated increased risk of death. Okay, that is what you need to understand. Later on in 2015, the proper study group actually did a multi-center randomized control trial. Okay, which compared 1 is to 1 is to 1 ratio with the 1 is to 1 is to 2 ratio. There was no significant difference in mortality. Okay, but what they saw was 1 is to 1 is to 1 group patient achieved better hemostasis, and fewer patients died because of bleeding, that is exsanguination, in the first 24 hours. So usually we think about transfusion and all in most likely in the first 24-hour period, right? So even though there was no big difference in the overall mortality rates, hemostasis was better achieved with a lower ratio. Okay, so that is one conclusion we have as of the proper trial. So the take home point would be both the proper and prompt showed that there is a higher risk of death if you give a patient receiving a higher transfusion, that is your 1 is to 1 is to 2. So they said that if the patient receives a 1 is to 1 is to 1 transfusion ratio, it achieved better hemostasis and lesser chances of exsanguination was seen. Okay. So let us take an example of MTP. So we keep telling of 1 is to 1 is to 1 ratio, when to give, what to give. So different hospitals will have different protocols and different understanding. So we can just take one example. Okay. So each center would be different. So, but is that the right thing? Is what we need to understand. Whether proper hemostasis is achieved or not is our final goal. Okay. That is what we need to understand. So consider a patient who is a male, weighs around 80 kgs and a severe gunshot abdominal wound with active hemorrhage going on. And his estimated blood loss was roughly around 2,500 ml or 2.5 liters. So, by this definition, he falls under class 4 hemorrhagic shock, correct? Because of this, if you see your RABT score, etc., also there is penetrating injury and blood loss is also higher. Probably I'm not going to get the other two parameters because there is no shock index that I can calculate, but by and large there would be bleeding, right? So that is itself going to give a score more than 2. So based on these things I can activate a MTP protocol. So what do I do? The blood bank has to be activated for such units. This fellow weighs around 80 kilos. The minimal PRBC transfusion that he would require is around 1200 ml. If each bag of PRBC consists of 200 ml, it is differing from one place to another. Okay, there are few places, few blood banks which have even 300 ml as well. But you have to understand that the bags depend on the volume of blood which is present in each bag. So if it's a 200 ml bag, you roughly need around 6 units of PRBC. If it's FFP that you're calculating, the usual calculation is between 12 to 15 ml per kg. I'm taking the lower end. So if we take it as 12 ml per kg for an 80 kg individual, roughly 960 ml would be required. So then again, you use a 6 unit FFP. Okay, so 1 is to 1. Platelet usually for 10 every 10 kgs you require 1 unit. Roughly you need 8 units, but in this case we can still ask for a 1 is to 1 is to 1 itself. Okay, thereby you can ask for a 6 units of platelets. You people might ask, 1 is to 1 is to 2 was there and that caused problem. The 2 there was for PRBCs. Okay, remember that one. Okay, it was blood which was given larger, not the platelet. Okay, here again it doesn't become 2. Okay, it's still lesser than 2. Okay, it's probably 1.12, something like that. Okay, the second MTP cycle, this you remember all of this, as soon as you initiate MTP it would be at the 0 minute. Okay, so after this you give all these blood products, that is 1.2 liters of PRBC, 960 mils of FFP, and probably 6 to 8 units of platelets. So you give this, roughly probably you'll take around 1 to 1.5 hour, correct? So by this time, you again do a test of your parameters. Probably you do an ABG, okay, or else you can also do send in a point of care testing. Okay, so if your point of care testing is also done and that also you cannot find out that the hemostasis is achieved, then you have to go for your second cycle of MTP. Usually this takes around roughly 30 minutes. Okay, your transfusion, everything should be matched, so prevent further time wasting whenever possible. But having said that, blood is a very essential and a rarely available commodity, so judicious use should be done. The second unit again would consist of same units: 6 additional units of blood, 6 additional units of FFP, and 6 units of platelet. At this particular time, you should already have got your fibrinogen levels, or your ROTEM or a TEG also should have given you the understanding of coagulopathy. Based on that, you can consider the use of cryo. So by these two things, if you have achieved your hemodynamics, you need to stop. So what are the criteria for stopping MTP? hemodynamic stabilization, okay, your vitals, your blood pressure, your heart rate, your signs of end organ perfusion would have happened. Laboratory parameters like a PTINR and hemoglobin would have stabilized. Any damage control surgery which was necessary at that particular time you should have been achieved. That is, any emergent indication for arresting the bleed, the surgical procedure should have been done. Later on, you can do a definitive procedure. Damage control intervention should have taken place. And based on this, you can have an interdisciplinary assessment and the surgeon's reevaluation so that the definitive surgery can happen within a span of the next 24 to 48 hours. Okay. When you've done all of this, you have to document, inform the blood bank officer, okay, that you are terminating MTP. Usually we forget that. That is the major thing that we need to remember. Okay, we need to terminate MTP by calling back the lab again, telling them that the patient has stabilized. We no further do no longer require blood products. What are the complications? Whenever there is complication secondary to blood transfusion, you need to classify them. This is a rough way I've just given it. Okay, please don't write it like this. If the complications they specifically ask about transfusion, classify them between early and late, okay, immunological and non-immunological, okay, something like that. But in general, because I'm talking about major massive transfusion protocol, the complications are transfusion associated acute lung injury, transfusion associated circulatory overload, dyselectrolytemia, hypothermia, coagulopathy because of dilution or consumption, okay, dilutional thrombocytopenia, metabolic acidosis, infections, per se trauma or transfusion related infections, ABM incompatibility, and ARDS. Thank you.
So what is cell salvage?
Cell salvage is actually an intraoperative procedure, actually majorly used in surgeries like spine injuries, etc., wherein the blood which is being lost at the site of surgery usually is transferred to a machine which actually separates the components of blood, purifies the blood, that is the patient's own blood, right? So based on that, they can use the patient this blood that would be collected into a citrated blood like any other blood product which is collected in the blood bank, and then you can use the same blood at the end of the procedure to be given to the same patient. This can be one of your things in your patients with Jehovah's Witnesses. Okay, so this is one of the auto transfusion protocols, if I would put it in a better term. Okay, so cell salvage is one of those techniques. Okay, there's a chat question. Yeah, so Pratap has asked whether platelets are RDP or STP. Usually, the availability matters. When I spoke about 6 units, it is the random donor platelets. Okay, that's a very good question. It's a very practical question. The one which usually is given in such cases is the random donor platelets. But if it's a single donor platelet, depending on the volume, and the number of the thrombocytopenia, single SDP should be sufficient enough. Okay, coming to the last talk of the day, damage control, resuscitation. Okay, is my slide visible? Okay. uh, it's just going to be the continuation of trauma induced coagulopathy and MTP again. Okay, so, by definition or introduction of DCR, it's a systematic approach again used to manage severely injured patients, particularly those who have life threatening hemorrhage. Usually, it is done to optimize survival, preventing the lethal triad of death. I think so. If I wake you up, guys, tomorrow in the morning or any time in the day, you would be repeating what is the lethal triad and diamond of death. Correct? So this is something. This is the main cornerstone which people have understood that is the harbinger of death in such patients. Correct? So this is what we try to offset. The concept is rooted in minimizing further physiological deterioration, which happens because of our interventions, then usually we try to stabilize the patient for definitive care. Okay, so it's a conscious effort from our side to prevent worsening of the homeostatic mechanisms which are already in situ. The components of damage control resuscitation are permissive hypotension, minimization of the use of crystalloids, early hemorrhage control, that is your damage control surgery, and rational use of blood products, that is your ratio of 1 is to 1 is to 1. Okay. Along with this, the principles of damage control surgery usually involve permissive hypotension, like I've already mentioned earlier, rapid definitive control of bleeding, either by surgery, interventional radiology, or transfusion. Okay, that depends on what is the cause of the bleed. It's coagulopathy or a trauma, or probably a smaller vessel which needs some embolization. In the meanwhile, you need to prevent the triad or diamond of death. That is your hypothermia, acidosis, and hypocalcemia. Okay. So, sorry. The pathophysiology usually involves a two-hit hypothesis. Okay. Can anyone unmute and tell me how this DCR came into picture? What is why? I mean, if you have read it earlier or anyone has mentioned to you, where does the terminology damage control come in? You guys have not read it. Okay. All these actually came in from military sources. Okay, the first time anything related to damage control was by the US Navy, and most of the things on damage control resuscitation is the World War One and Two. This is where things have actually helped us. Wars have always helped medicine advance, so this is one of the other places where it helped us understand treatment of trauma and associated issues. Okay, so basically US Navy, whenever there was a vessel which was hit, okay, to prevent the sinking of the vessel, they had to do some damage control. So that is how the word or the terminology of damage control came into picture. Okay, so coming to the topic per se, the pathophysiology usually involves two things: the first hit and the second hit hypothesis, like you see in your neoplasia also. First hit is initiation of the systemic inflammatory response, which is usually due to trauma. Okay, because of SIRS setting in because of trauma, that leads to an imbalance in the inflammatory mechanism. Right, there is an imbalance between your pro and the anti-inflammatory parameters. If this first hit is already present, and you by your resuscitative mechanisms don't consider this, you cause the second hit, that is the time dependent state, which leads to further insult. Okay, that can further tip the balance off and make the patient end up in a state of coagulopathy, leading to life threatening hemorrhage and death. Okay, this is usually the first hit and the second hit hypothesis for damage control resuscitation. Okay, so what happens? There will be trauma. Okay, there will be activation of the lethal triad. There is an imbalance between the procoagulant anticoagulant pathway. There will be an endogenous response. If we have not taken any action, there would be occurrence of trauma induced coagulopathy, and if this is left unchecked, it can cause death. Okay, so, like we already saw in trauma induced coagulopathy, there will be hemorrhage, hypovolemia, tissue hypoxia, which causes hypothermia, acidosis, and coagulopathy. That is your lethal triad of death that causes acute coagulopathy of trauma. Okay, along with your environmental factors, this would worsen. Damage control resuscitation usually helps us prevent all of this. This is, it helps us understand how to manage hemorrhage. It helps us understand how to manage hypovolemia, hypothermia, acidosis, and tissue hypoxia. By doing this, we can control the hemorrhage or the occurrence of coagulopathy and then prevent death. Okay. So, when and in whom do we initiate damage control resuscitation? Previously, when things were not done routinely or widespread evidence was not there, it was considered that it has to be done in a hospital setting. Okay, majorly they thought this has to be still done in an operative theater. Okay, this is majorly because this was done in field hospitals, secondary to war injuries. But over time, when we understood that if things are done in a right and a protocolized way, outcomes are better. Correct. So that is why they instituted that earlier initiation of damage control resuscitation would have better outcomes. So it starts with the pre-hospital management, goes on with consideration of optimal volume resuscitation, and along with that, the emergency surgery, that is your damage control surgery, restoration of hemodynamics and physiology, and then progressing towards a definitive treatment which restores homeostasis. Okay, so this is the evolution of damage control surgery. Okay, from a field hospital or a operative room to by and large the whole hospital, be starting from actually the time of arrival in the paramedics. So if we have a good paramedic system in our country, we can also think of doing this. So West is already doing it better, but yeah, it starts from the site of injury. Okay, so phase zero of damage control in resuscitation takes into consideration the injury recognition, rapid triaging, and transport of the patient. Phase one is the damage control surgery. Phase two is interventions, balanced, hypotension, hemostatic resuscitation. Phase three constitutes definitive surgery, and phase four usually reconstructive surgery. Okay, this is what is by and large looking at damage control resuscitation. So four phases are present. Okay, recognize the injury, transport the patient, arrest the bleeding by emergency damage control surgery or interventions, optimize hemostasis either by products or by ligation or by any other method available, make sure the vitals are stabilized, then progress towards definitive surgery. Once that has happened, later on you can plan for reconstructive surgery. Okay, so the approach usually takes into consideration two things: what is the anatomical injury of the patient, what is the physiological derangement because of trauma. Okay, so the anatomical parameters of damage control resuscitation usually should include more than one of the following parameters. There is something called as injury severity score that you guys have to read up. Okay, no need to remember everything in detail, but better to know some of the components. Okay, if you are talking about trauma, they will definitely ask you how is it categorized. Okay, one of the objective tools that you can use is an ISS, that is your injury severity score. If the score is more than 36, the type of trauma is a penetrating trauma. If the fracture involved is an unstable fracture or a long bone fracture, and if the patient has amputation or truncal hemorrhage, these are the patients who require damage control resuscitation. The physiological parameters which require DCR are extremities of shock, that is your absent or weak radial pulse, hypothermia, and a tachycardia of more than 100 beats per minute. Remember, there is no single criteria or an isolated criteria which makes a case. Usually, both have to be considered your anatomical and physiological parameters, and based on both of them, you need to take a decision for the initiation of damage control resuscitation. So you need to know there are a lot of indications. Okay, it can be blunt trauma to the abdomen or the chest. Okay, and the complexity of the trauma should be considered. Okay, if it's a multi-region trauma, that has to be also considered. Always remember, rule out the presence of a traumatic brain injury, because few of the components of DCR cannot be initiated with patients on traumatic brain injury. Okay, if the patient is having TBI, there's permissive hypotension that cannot be initiated on such patients. Okay, if it is done also, the cutoff for that would be different. Okay, so if you have understood all of this, this is how a patient has to be managed. Okay, so patient has been a person who has been conceptualized as to receive DCR. The first thing they do in DCR is a damage control surgery, and then go on for the other two, which I've mentioned earlier. The other two components that will go hand in hand along with damage control surgery are balanced resuscitation and hemostatic resuscitation. Balanced resuscitation is with permissive hypotension with the minimalization of use of crystalloids and rational use of blood products. And if the patient is having a major trauma based on your scores, which I've mentioned earlier, okay, you can initiate or activate MTP. Okay, usually the damage control resuscitation, damage control surgery, balanced resuscitation, and hemostatic resuscitation should be optimized within a period of first 24 hours. Okay, so from the time of the insult to now, that has to be completed. Definitive surgery, once you have achieved the arrest of bleed, you can think about doing a definitive surgery, that is roughly between 2 to 3 days. After everything is over, the patient is completely recovered, then you can think about reconstructive surgeries. Okay. The key components of DCR include early hemorrhage control to stop bleeding, permissive hypotension to maintain lower than normal BP, where the main important thing is you have to maintain adequate perfusion to vital organs. Okay, it's not jeopardizing them. Balanced transfusion, that is the ratio which is given to by us by the proper and the prompt trial. As a minimal crystalloid use as possible should be the goal, because over inadvertent use of crystalloids can cause dilutional coagulopathy. Okay, so one important thing is the ATLS, remember, 1 liter, that is what has been mentioned. Okay, that itself is sufficient enough for us to tell whether the patient is a responder or a non-responder. Correction of coagulopathy with the use of adjuncts like tranexamic acid, where prevent hypothermia and management of acidosis. So this is by and large what is the whole thing about damage control resuscitation. If a question is asked to you, okay, if you write this diagram, okay, it has to consist of damage control surgery, balanced resuscitation, hemostatic resuscitation, minimalization of crystalloids, permissive hypotension, this ratio that has to be remembered. Hemostatic resuscitation, that is your activation of your massive transfusion protocol, or depending on coagulation or coagulopathy, you can use any other blood products. Try and arrest the bleed within the first 24-hour period. Once that is done, you can do your definitive surgery. And once the patient is stable, do a reconstructive surgery. Okay. The individual components are early hemorrhage control, permissive hypotension, balanced transfusion, minimalization of crystalloid use, coagulopathy, tranexamic acid is something that they look at. Prevention of the lethal triad of death also you have to write. Okay. So this is, if you write so much about DCR, if they ask you an exam, that is more than enough. For you to understand the fewer nuances of trauma, I've added the further slides. Okay. How is it different compared to any other case that we need to think about trauma management? What is the changing paradigm that is seen in trauma management? If any patient arrests in the ICU, what do you do? Suddenly becomes unresponsive. How do you manage? What is the usual go-to thing that we do? Patient comes to your ER. You assess the patient. Patient develops shock, then worsening sensorium. Then you need to do something. What do you do? Hello, are you guys there? One of you can unmute and answer. It's a very simple, open question, right?
CPR,
CPR, yes, definitely yes. Before that,
intubation,
okay, how will you assess? Intubation, correct. So all of this is correct. I'm not telling they are wrong, but you go in a systematic way, right? You see, it's a case of
DCR,
cardiac arrest. So whenever you get such questions, right?
ABCD.
Yeah, good. ABCD is correct. Again, these can be an indirect question in your, practical exam where the examiner wants to know how you're going to do. It's a case of cardiac arrest, maybe yes. So start with your scene safety. Okay, if they ask a question like this, okay, randomly they'll be discussing and they might throw in a question like this in Viva sessions. So understand the question and answer. Okay. So here I was wanting you to answer in that particular order. Correct. ABC is what something that I wanted to know. Okay. So airway, breathing, circulation, right? So if someone says the patient becomes unresponsive, correct, you have to start CPR at that particular time. I would search for your scene safety, then followed by the next things. Okay, call for help, look whether the patient is breathing. Okay, all of that. It has to go in according to your ACLS protocol. Okay, that has to happen. In that way, ABC is the thing that we see for all patients, right? So, what is the changing paradigm in trauma?
It was CAB.
Correct. What is C in that?
COPD.
Yeah. What is C?
Compression.
It is actually compression. Good. That is one thing I'm happy to hear. Okay. So actually, it stands for catastrophe. Okay, catastrophic hemorrhage. Okay, it's actually CABC. Okay, what we usually forget is we forget the uh, C again. C there stands for catastrophic hemorrhage. Okay, this is what you guys have to remember. Okay, rest everything is similar. Okay, A, B, C, D, E remains there. Along with this, you have to add the C. It is for a catastrophic hemorrhage. So there you can use a compression if it is a compressible type of a hemorrhage. Okay, so whoever said compression, good. But yeah, the thing is C stands for catastrophic hemorrhage. Okay, usually utilizes something like a tourniquet. Okay, topical hemostatic agent or field resting, so on and so forth. Okay, controlling the bleeding is very important when a patient comes with a trauma to you with a very catastrophic hemorrhage. Okay, it starts at the point of injury. Direct pressure or hemostatic agents can be used. Riboa is one way that you can use, or an abdominal aorta junctional tourniquet. Okay, so abdominal aorta junctional tourniquet, Riboa is something that depends on the availability. If they are available, well and good. Otherwise, damage control surgery should be initiated. Can anyone unmute and tell what is Riboa? Okay, okay, it stands for
Endovascular balloon, basically.
yeah.
Resus-
Balloon of iota.
Okay, correct. Okay,
SST.
remember this
Below.
resuscitative endovascular balloon occlusion of the aorta. So all of you, I think so, know intra-aortic balloon pump (IABP), right? It works on counter pulsation therapy. Yeah, just remember that this doesn't have any pulsations. Okay, it just have an occlusion. Okay, I'll show you the diagram which will help you understand. It's only for a time-saving bridging therapy. Okay, so if you feel that there is a major hemorrhage which is happening in the lower limbs, you're unable to give any compression and arrest the bleeding, you can use one of these techniques. That is your AAJT, that is your abdominal aorta junctional tourniquet, or your RIBOA, that is your resuscitative endovascular balloon occlusion of the aorta. If at all you can do pelvic binding, splinting of long bones, etc., to prevent further bleeding, that would be good. The first thing is arrest the bleeding. That is what you have to do. Okay. Later on, when you have arrested, but still you see there is hypotension, the patient is requiring a lot of transfusion, you might have to do a multi-site CT to assess the site of bleed as well as the severity of bleed and damage of organs, if any. So RIBOA, it stands for resuscitative endovascular balloon occlusion of the aorta. Okay, usually used in severe hemorrhagic shock, uncontrolled bleeding, and non-compressible torso hemorrhage. Mechanism, it just prevents the distal flow wherever it is present. But the most important thing is it keeps blood flow to the brain intact. Okay, vital organs like the brain and heart are untouched. It is usually used for injuries below the umbilicus. That's a rough vague idea to remember. Okay, so usually there are three zones which are present. Okay, from the left subclavian downwards till the celiac artery is the first zone. Celiac artery to the renal arteries is the second zone, and renal arteries to the bifurcation is the third zone. Zone 2, you shouldn't do it because you're directly going to affect the blood supply to the kidneys. Only thing they say is zone 1 you can use, but the time is only up to 90 minutes. Okay, sorry, 60 minutes. If it is zone 1, it is 60 minutes. Zone 3, you can go up to 90 minutes. Why it's 60 minutes here is because 30 minutes itself you should try and find out the source of bleed and arrest it as much as possible. Beyond this, indirectly it definitely would affect the abdominal viscera and the kidneys. Okay, so it's a life-saving procedure. That is one thing. Zone 2 definitely no, because it directly affects the kidney. Okay, but yeah, if you cannot do anything, you can still use it here also. The best thing is infrarenal artery position. Okay, so here most of the abdominal viscera would be left without any issues, and even the renal perfusion would not have a problem. Okay, so this is usually done to buy time for a definitive treatment. Most of the times, or always, the approach is the femoral approach. Okay, so usually it will be inserted in the femoral artery and go on upwards. So coming to the role of radiology, okay, so usually either it is for a diagnostic purpose, so it is called as radiology in DCR. Okay, it can be used for knowing where the bleed is. Sometimes you can use that as even a therapeutic procedure. How? By doing interventional procedures like an angioembolization, etc. Okay. So how do we go about? First, you do an E-fast. Look if there is any presence of a free fluid in the cavity anywhere. Do a CT polytrauma with an angiogram. If you feel that it is amenable for angioembolization, then you can consider angioembolization depending on the availability of your IR specialist. Phases of DCR: initial surgery, like a DCR, better to do the surgery as early as possible. Okay, the only aim is to control bleeding. Okay, in the meanwhile you have to prevent any cross contamination. Okay, make sure that you do the procedure as early as possible. Transfer the patient to the ICU, correct your coagulopathies. Your balanced resuscitation should happen here. Your hemostatic resuscitation also should happen in the phase 2. Phase 3 is your definitive surgery, which is roughly after 24 to 48 hours. Okay. Permissive hypotension, I told you, it is something that we usually do to maintain perfusion to vital organs. But we have to understand this. The mechanism where they think is by increasing the blood pressure, we might pop the clot. Okay. There is no widespread evidence for it still. Okay, what is assumed is if we increase the blood pressure, the bleeding also will worsen. So for that reason, for the initial time period of the damage control surgery and hemostatic resuscitation for a period of 24 hours, permissive hypotension can be tried. Okay, most importantly, remember the target blood pressure is 80 to 90 millimeters of mercury in patients without traumatic brain injury. Okay. If the patient has a TBI, the SBP should definitely be more than 110 millimeters of mercury. Okay. Challenges, definitely we don't know whether it is good. There have been multiple studies which has shown there is a risk of acute kidney injury which can happen. Only that particular time what we are looking at as a life-saving tool. Okay, only if you're desperate enough you can do that, but if you're targeting your map targets higher, your inotropes etc, probably you can use that as your target. Probably a 90 of hg supposed to be sufficient enough. Okay. Also remember, patient with multiple comorbidities like a cardiovascular comorbidities or patients with kidney injuries or a prior stroke, they might not tolerate hypotension as much as the patients with a younger age group with no comorbidities. Okay. So balanced resuscitation, it's usually to minimize the ill effects of excessive use of crystalloids. It can be the exacerbation of acidosis, coagulopathy, or hypothermia, which is the constituent of lethal triad. Okay, so this is what we need to know. Balanced crystalloids. Remember, inadvertent use of excessive crystalloids can worsen the coagulopathy. So main thing in balance resuscitation is restore the circulatory volume, optimize the coagulation, and prevent any metabolic derangement. Okay. So I've already mentioned about the things, the requirement of each blood product when I've spoken to you about massive transfusion protocol. It's similar to those. The whole thing is each thing focuses on a particular entity of homeostasis. Like PRBCs, it focuses on restoring the oxygen carrying capacity. FFP focuses on replacing the clotting factors. Platelets is for the stabilization of the clot. Fibrinogen and cryoprecipitate is for the strength of the clot. Ratios I've already mentioned earlier, 1:1:1. Over resuscitation, we know it can cause pulmonary edema, worsening of hemorrhage due to coagulopathy, and also the occurrence of abdominal compartment syndrome. Calcium repletion, I've told you earlier, 4 to 6 products whenever you're using. Look at the ionized calcium, less than 1, supplement it. Either calcium chloride or calcium gluconate. Okay. So colloids better avoid, crystalloids minimized up to 1 liter, tranexamic acid as early as possible. Monitoring parameters, heart rate, blood pressure targets you already know. MAP targets roughly around 60 to 65. Tissue perfusion, you can check your lactate and base deficit. Okay. Venous oxygen, if you're doing a VBG, probably better to target more than equal to 65%. Okay. There have been multiple trials which are coming off lately. Your capillary refill time itself should be sufficient enough based on your Andromeda shock trial, right? Coagulation parameters, like any other, coagulopathy, target an INF less than 1.5. Any patient with traumatic brain injury, platelet count, if at all planned for an emergent surgery, should be roughly targeted over 80,000 to 1 lakh. Okay. Temperature should be always kept in normothermia, avoid hypothermia. Target usually is about 36 degrees Celsius. Oxygenation target, whenever you're doing, maintain a PaO2 level of more than 60 millimeters of mercury. Urine output, the target by and large, what they say is more than 0.5 ml per kg per hour in adults. Okay. So roughly this is the targets in summary. Evidence, proper trial for the ratios, crash trial for tranexamic acid. For DCR per se, there is a trial by Mattox et al. Which said that in the military population, when they said early advocation of balanced resuscitation helps in better outcomes. Okay, thank you. Any questions? Yes, Joshna, the Riboa zone 1 is 60 minutes. Better to do it 30 to 60 minutes. Zone 3 is less than 90 minutes. That's correct. Okay. If there's anything else, please feel free to message in the group. Okay. Thank you. There is a class on ARDS, which is a recorded session, and there have been multiple queries about CRAB and CRE. I've informed the specific person who has to give it to us, so they will be sharing it to you soon. Okay. In the meanwhile, you can read up. The aim is to give it to you as early as possible. Roughly, I'm giving a deadline of 17th, so that 1 month target would be there. Okay, 17th or 18th, you should be having all the presentations on board. Okay. So all the best. Probably we'll be meeting you for the debrief on the 22nd of December. Please attempt it. Please make a conscious effort to write the answers, whatever, so how much ever you know. Don't expect you to recall 100%. Okay, 60% or 50% of recall is good enough. Okay, write it. Okay, so that you can remember. If out of the 10 questions that we discuss, even 1 or 2 comes, it will definitely help you and boosting your morale on the day of exam. So think about it. Okay, all the best and good night.